And good morning, it's Dr. Duke Majan. It is February 21st, 2023. Today we're going to be performing the Duke laser disc repair, which is essentially a surgery designed to fix a bulging or herniated disc. And in this particular patient, we're going to go cervical. Today's a special day because, and by the way, I'd already touched the skin with the needle, but I stopped because I wanted you all to see how I do this. We're going to be doing a cervical DLDR, a thoracic DLDR, and a lumbar DLDR, all in one day. And we're going to be doing two plasma rhizotomy, Duke plasma rhizotomy for facet joint pain. So there's two separate types of procedures being done today, throughout the day. The first is to treat a disc problem. The second is to treat a facet joint problem. Those are the two types of joints in the spine. So we're going to get started. This particular patient's had 6 or 7 months of neck pain. He has pain that radiates from his neck into his head and down into his arms. He's got numbness and tingling. So these symptoms are coming from two discs that are what we call disc bulges, because they are small herniations, not big herniations. Most doctors would pass them up. They would send the patients to pain management. Is that really the pressure? And the patient would live in pain the rest of their life. But at Duke Spine Institute, we found that there's a small tear in the back of the disc associated with this herniation, the small herniation, and that's where the patient's pain comes from. So the first maneuver, this is the patient's chin, their face, they're looking up at you, the camera, their chest is here. This is a male. The middle of his neck is right about here. So if you were to draw a line from your chin, this is his chin. Right down the center of the neck, this is about the middle, all right? Right to the sternal notch right here, okay? Just to give you an idea where the center is. So I'm on his right side, and I've never described in detail what I do, but I use leaded gloves, and I'm going to press just medial to the sternocleidomastoid. And I'm touching his spine right now. Believe it or not, I can feel the spine. I'm going to go between my two fingers with the needle, and I'm going to use my lateral fluoro. 2, 3, 4, 5, 6, 7. So I want to be, if I'm doing two discs, I want to be over the middle bone, the bone between the two discs. That's where I want to start. All right? And what up there, I could be a little higher. Shot? All right, so that's perfect. So I'm going to start with 6, 7. So I'm going to slide my hands down. Go on. It's too much. Right there. Shot. Perfect. And now I'm going to use an AP. Everyone agree that's 6, 7? I want to make sure my tip is over the center. Quick shot. Quick AP. It's not a slow AP. So I'm a little bit to my side. I need to go a little bit more towards the middle. To do that, I'm going to shove my fingers along the spine, rolling them, and pushing everything over. Shot. All right, so that should be center right about there. I'm going to go in. I feel the annulus fibrosis. I want to get one more AP just to verify I'm in the middle. So quick 1, 2, 3, 4, 5, 6, 7. Meanwhile, I'm counting. Remember, my fingers are getting radiated, which sucks. There we are. We're in the middle. You see the spinous process? Show them the spinous process. I'm inside the disc. Show them the spinous process. Good. And that means we're in the middle. And let's get a lateral view. So we're inside. While you guys were watching that, I popped in. I could feel my needle go through the annulus. Now that we're inside the disc, let's just count one more time. Everyone should get the same count. 2, 3, 4, 5, 6, 7. Everyone agree? All right. So we're in about the middle of the disc with this needle. I'm going to inject a dye, two types of dye. One is for the X-ray machine. There we go. And you see the tear. So wait a second. Let's get one more shot. Let's pull the shoulders so we get a good picture. And hold on. Shot. Shot. All right. Show the tear in the back of the disc. There you go. Right there. It's a pretty big tear. On MRI, it doesn't look that bad. And there's something else here. Look at this listhesis. Show the back of the C7. There. Show the back of C6. There. It's actually about 2 or 3 millimeters, maybe 4 millimeters of listhesis. C6 is sliding forward. Now show the dye in the epidural space right there. Yeah, that dye right there is behind the disc. That means it leaked out through the tear. That's the tear we're after, because that's where all of his pain is coming from. And it's that same leakage pattern that you're seeing there on the x-ray. That's the inflammation in the back of the disc that leaks out into the epidural space, just like the dye did. In other words, the whole basis of this patient's symptoms of headaches, neck pain, arm symptoms comes from a leakage, just like the dye in that picture, from inflammatory junk and chemicals out through the tear along the dura. And that's what causes the symptoms. We call that a cervicogenic headache. We call it cervical brachial syndrome, where it goes down into the shoulders, the pain, and then we call it cervical radiculitis or radiculopathy. Symptoms in the arms, okay? Now, number one, the couple of things to know about this. Most spine surgeons wouldn't do spine surgery because they don't know how to do the endoscopic tooth laser disc repair. So instead, they're going to think about, what do they have available? Well, I have fusion, I have artificial discs, and most spine surgeons aren't going to fuse an MRI that's almost normal. There's no reason for it. So they're very limited in their options to help patients like this. They really can't help them. They just send them to pain management. I've just made a 4mm incision. You see that, Henry? Literally 4 millimeters. We're going to do the whole surgery through that little incision right there. All right, next shot. I'm going to take the guide wire, leave it in. I'm going to take the needle out. Let's see. So I'm taking the needle out, leaving the guide wire in. Everything okay? All right. Our patient is stable, doing well. All right, now take a look. We've got the incision, 4 millimeters. We've got the dilator and the guide wire. We're going to head down the dilator, down the guide wire. And we're passing the carotid artery, the jugular vein. Shot. We're passing the trachea and esophagus. Show us the esophageal probe. It's braided on the x-ray here, Henry. That's the esophageal probe. It's a temperature probe in the esophagus. We put it so we can see where the esophagus is, okay? And then, of course, show us the endotracheal tube. Yes. So there's the endotracheal tube in his trachea. Shot. Beautiful. So now we're at the front of the disc at C6-7. Everyone see that? Count the vertebrae. 2, 3, 4, 5, 6, 7. We're at the C6-7 disc. Let's go ahead and get an anterior view. Make sure the tip of the dilator is in the middle. Now, I get a lot of questions from people. Dr. Duke, when you put the tube through the front of the disc, doesn't that damage the disc? The answer is no, it doesn't, because if you look at the dilator tip, it's tapered, meaning it's designed to spread the fibers. Look at that. At the center, look at the tip of the dilator. We're dead center, perfect, and the guide wire goes off to his left side, which is where he's having the most symptoms. Okay? And look, wait, stay there on the AP, stay there. Show them the dye around the nerve roots. It's beautiful. You can see the C5 nerve root, and you can see the C6 nerve root and the C7 nerve root. Go to the other side. Look at that, guys. This is incredible. Hey, this is, Henry, this is a very important picture. Save this AP. Take AP view. Can you save it?
Yes, I can.
So you could see the dye along the two nerves. I've never seen that before, that clear. Go to the other side. It's really clear on the left. There's one nerve, and then show them the other nerve. There it is. Incredible, huh? We've never seen it that good. That is a priceless picture right there of how a discogram and how a tear in a disc can actually travel along the nerve roots. That's how you get arm symptoms, guys. That's why he's having arm symptoms, even though he doesn't have a giant herniation. Henry, that's a very important picture. Are you sure you got it?
I got it, no worries.
That AP? Okay, save that for me in my special folder. It's very important. That's something that has to be published. All right. And used in lectures. That's a very, 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 very important picture. I've never seen anything like that. I mean, I understand it, how it happens, but I've never seen it so beautiful. I'm really excited about that. That's like, that made my day, that picture right there. You know, people wonder, oh, I've got arm pain, you know, from my neck. And then the doctor looks at their MRI and says, no, you don't. You're faking it. Go back to work, you know. And the reality is they're not faking it, because it's not about pressure. It's about chemical irritation. And seeing that image of the nerves lighting up with the dye, all we did was inject the dye in the middle of the disc. It leaked out through the tear in the back. And basically, it's putting irritation of those nerve roots, clearly seen. And that's why he has arm symptoms. And I'm so happy that his insurance company agreed to pay for his surgery, because it means a lot that they actually care and want this patient better. And I'm so excited seeing that. You have no idea. That literally is, my birthday was this month, and that was like the best birthday present I could have. So Henry, that is the most important picture we've taken, like literally this year. So please.
Copy that.
Shot. All right, so as I'm putting the tube in, you can see the dilator moved away. It shifted backwards, and I don't want that. There's a reason for that, and that is that this disc is under pressure. Shot. Okay, shot again. Okay, so yeah, the dilator went all the way back in. I don't want that. Now, if I just keep going, I'm going to biopsy the disc, and I don't want to biopsy the disc. My goal is to get to the back of the disc and take the herniation out, clean out the tear. Shot. All right. But every time I hammer one time, it literally, the pressure inside the disc from the inflammation, I could feel it. There's so much inflammation in this disc. This is causing his neck pain. Okay, so guys, this is incredible, incredible. I want you to listen to me here. There's inflammation because he's got a tear. He's got nuclear material in the tear causing inflammation. That inflammation is getting into the disc. It's creating pressure in the disc. So guess what that pressure does? It pushes the inflammatory material out through the tear along the nerve roots. And that's where he gets all of his symptoms from. It's just, I don't know why other people don't understand this stuff. And they don't treat these patients. They just leave them to languish. Shot. Look at that. Every time I put the dilator in, it keeps popping back from the pressure. That's how much pressure is inside this disc. Shot. I just have to be really careful because I don't want to push the dilator into the spinal cord. Shot. All right, so let's try again. Almost done. All right, now we're at the back of the disc, so that's perfect. So I'm going to tell you guys, look at that MRI. You look at it and you go, I don't see anything wrong. But what's wrong is there's a tear. So let's show our audience the video on how a annular tear disc herniation actually causes neck pain and headaches and arm symptoms.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, Submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are now inside the herniation and the tear. Look at the tear, guys. It's from the left, the white stuff, to the right. And all the blue is the herniation. And I could tell this herniation happened literally about 7 months ago. I can tell based on what I'm seeing. So it confirms what the patient said about injuring his neck at work, actually. Yep. And this disc is very swollen, very edema. If you've ever had an injury, anything in your body, you've noticed that the tissues swell. They swell up after the injury. They last a few weeks. That swelling is part of your inflammatory response, the response of your body. It produces inflammation, which is your body's response to injury. Okay? And it's poorly understood what triggers the inflammatory response, but the inflammatory cascade, which is essentially a series of many physiological changes and biochemical and molecular changes at the molecular biology level, genetic level, with gene expression that occurs when you have an injury, okay? We know that there's a complement cascade, that's not really activated in the case of a disc injury, but it is activated with bacterial pathogens when they invade your body. So this is a different kind of inflammation than, say, a bacterial invasion inflammation. Okay, just because I don't think you activate the complement system. But it's the same in terms of swelling and pain that you get with inflammation, okay, and scarring over time. This is all the annular tear. You guys see the crack? That is the annular tear. That crack shouldn't be there. In a normal disc, it's not there. This tube is a little sticky. All right. Now, his tear, if you notice from the last picture, Henry, is on both sides. And you could see the nerves on both sides. That means that oh, by the way, this is fascinating. Oh man, levels of fascination are just enormous here. Did you see that we injected the dye into one disc, right? C6-7? How many nerves lit up? 4. The traditional teaching is that each disc affects 2 nerves, not 4. Not 4. My God, this is history making. I just get so excited about what's happening here. We saw 4 nerves. So that goes against all traditional models that doctors use when describing a herniated disc and the effects of the herniation. They always talk about how, oh yeah, C6-7 disc is going to affect the C7 nerve root. No, it affected the C6 and the C7 nerve root, both, on both sides. Everything okay? My point is, all this teaching that we've gotten, all these years, all these things we believe in spine, they're not accurate. And what's accurate truly is the patient. The patient is our best teacher. And I heard that as a medical student from the dean at USC, where I went to med school, the dean of the medical school. He came in and said, you're going to find that all these textbooks and everything, your best teacher is your patients. Huh? Hippocrates said that? Well, and Hippocrates was not a hypocrite, but he was hypocritical. All right, what are we seeing back here? These are, huh? These are the fibers of the posterior longitudinal ligament. All right, there's the foramen, the left neuroforamen. We're going to get back to that in a minute, but I'm going to clean all the herniation out from the back of this disc. All this, and you can see why that is the gateway to the epidural space right there, all right? The gateway to the there's a piece of herniation. That blue thing that just floated up. All righty. So far, he's doing really well. I just talked to his wife and him. You know, he was in a car accident, and he was at work, and he injured his neck. And when was that injury? It was like 9 months ago? 7 months ago. So this is exactly what a 7-month-old herniation looks like, folks. You know, it's exactly what a 7-month-old herniation looks like. Look at the blue. All that blue is degenerated nucleus pulposus. It's all swollen, edematous. That's what was pushing this dilator out of the disc, like literally shoving it out. Oh yeah, baby. These are all pieces of herniation, okay? Just about done. Oh, there's another piece. Beautiful. Okay? Questions from our audience? Oh, another herniation.
No current questions, but we do have a couple comments of saying good morning from Liz Lindsay and SARS Logistics.
All right. Good morning, guys. Good morning. It is a good morning. It's been a really informative morning. And I'd like you to run our video. Have we done the one on how the Duke laser disc repair actually fixes the discs?
Not yet.
Let's do that so everyone can see.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. And as you can see, the laser we talk about in our video is at 12 o'clock position. There's the tip of the laser fiber. It's made out of glass. It's a fiber optic cable, basically. Not an expensive one. I mean, it's expensive for us, but not like the ones they use for transmitting the internet under the ocean. Those are extremely expensive fiber optic cables. They have to be almost perfect optics. This is not that way, but it's good enough for medical use, and each one of these runs around 150 bucks, right? More? Oh my God, they raised the prices that much? Jesus. All right, I guess they're more expensive now. Oh, Luis's eyes are popping. So they're very expensive. Yeah. These are all pieces of herniation, the blue stuff, okay? That is what we want to get out. Now, it's not just herniation. The blue is very important. It's degenerated nucleus pulposus, okay? So the herniation is actually the nucleus pulposus, but the normal nucleus is white. The normal nucleus is white in color. And when you put this dye in, it will not stain a normal nucleus blue. It only stains acidic. That's acidic, ACIDIC, pH less than 7.4. It will only stain acidic nucleus pulposus, this dye, the blue dye, the Duke spine dye, okay? So by staining right here, the blue, that tells me that's damaged and degenerated nucleus. That's bad stuff. It needs to come out, period. okay? Try to get out as much as I can. This brings up another point. When a surgeon does surgery for a herniated disc, we never get 100%. It's not possible. No human being can get 100% of the herniation out. There's no technique. So even if you do a fusion, you're still not getting 100% of the disc out. So what percent are we getting out? Usually, if you're a good surgeon and you have good technique, you're going to get out around 70%. You need about 50% to get a therapeutic effect on average. Rule of thumb, 50% has to be removed, 50% of the mass of the herniation, okay? By the time patients present to the doctor and they've got symptoms from a herniated disc, you need about 50% to come out, all right? So I figure my average is somewhere around 60% of the herniation. So some of the questions I get, Dr. Dukmajian, if you remove the disc, what's going to fill its space? I'm not removing the disc. If you have noticed, I'm only removing the herniation. The herniation is not part of the disc. The herniation is something outside the disc. That's why it's called a herniation, because it's left the disc and it's in a place it shouldn't be. So I don't ever remove the actual disc because I want you to keep your disc. Dr. Dukmajian, how do you know when to stop? Well, for the most part, I can tell what I'm dealing with anatomically. These are fibers of the posterior ligament, just down there, those white fibers right there. And that's not herniation. That's actually posterior ligament fibers. So I think I'm done. I'm looking out his foramen right now. I want to show you guys this before we're done. By the way, the bone on the right side is C7. The bone on the left side is C6. We are literally inside the foramen at C6-7. That's the foramen right there. Hold on a second. Let me get this piece of damaged tissue out. All right. See the foramen there? There's actually the nerve root. You can see it, the blue, right there at the base. That's the nerve root down there. There's a little bit of ligament just above the nerve root right there. I'm just zapping that. You don't even need to. It's not putting any pressure. See the shiny blue surface? That is the nerve root. Okay, that's the dura mater of the nerve. So I know I've done a good job of decompressing. We're done. So I've removed the herniation in the foramen on the left. We had worse left-sided symptoms. And we've debrided the annular tear. We've removed the degenerated nucleus pulposus, which is the herniated nucleus that's been acted on by inflammation. Remember, this is an inflammatory condition, inflammatory disease. All neurosurgeons don't understand that. They all think it's a structural pressure. That's why they call it decompression, because they're trying to decompress something. But there is nothing to decompress here, except maybe the pressure in the disc. Okay? Conventional neurosurgery and spine surgery has this disease all wrong. This is not a compression disease. This is an inflammatory disease. And it needs to be treated as such to successfully get rid of patient's symptoms. I want you to look. We're now done with the first level. Now we're going to use the same incision, and we're going to go up to C5-C6. So we're doing 2 discs, with one 4mm incision. This is a 4mm incision, folks. Forget about ACDF surgery. Let's go. Oh, we can't show the comparison. We'll show you a comparison later. There's a comparison video. You can compare the 2 surgeries, ACDF versus Duke laser disc repair. For those of you wondering, this surgery has been peer-reviewed and published many times in the medical literature. It's been published as safe and effective for the treatment of symptomatic disc disease. That includes annular tears like this patient has with a bulging disc, or an annular tear with a herniation, or a degenerative disc. All of those conditions are treated. So there's the x-ray. We need to see C2. Perfect. So I'm going to take the apparatus out of C6-7 because we've now treated the herniation and annular tear. We're going to go into C5-6, one level up. You guys ready? So this is a technique that I developed when I learned endoscopic surgery from the Koreans and a German surgeon. They were doing one level, one disc. That's it. They were done. I modified the technique to be able to do 2, 3, even 4 discs, okay, with 1 surgery. But this is the step that they don't know how to do that I developed myself with go ahead.
Thank you.
Yeah, go ahead. All right, so you got to take out the tube and leave the dilator, all right? And at this point, what I'm going to do is I'm going to slide the tip of the dilator out of the disc, so I'm backing it out, and I can actually feel when I'm out of the disc. Right there, I'm out. I can feel it. Now, I want to stay in the middle, okay? So I have to use an AP view, and I'm not lifting the tip off the front of the spine. You must not take the tip off the front of the spine. As you come out of the hole, you must stay on the ALL, anterior longitudinal ligament. Perfect. And I'm in the midline. You guys see the spinous process? Show them, Jordan. Show them the esophageal temperature probe and the esophageal endotracheal tube. So, first the midline. There's the middle. You see the spinous process? Yep. Now the endotracheal tube. This continuous line. And now the braided esophageal. So you can see how I've displaced the esophagus to the side. His left side, basically. All right. X-ray. So I'm in the midline. Now I need to crawl up the ALL. Again, this is a technique that I personally developed at Duke Spine Institute here in Florida about 16 years ago. Let's get an AP. So the initial 1-level disc was taught to me by the Koreans in terms of endoscopic technique in German. Dr. Sebastian Reuten, Dr. Sang-Ho Lee, Dr. Gun Choi were my teachers for the initial anterior cervical. And then, of course, they were doing 1 disc at a time and migrating to a 2nd and a 3rd disc during the same operation as what we developed at Duke Spine Institute. So a multi-level anterior cervical endoscopic procedure was developed here at the Duke Spine Institute in Florida.
Saves a lot of anesthesia.
It does. It's better for the patient as long as it can be done safely. All right, we're going through the ALL. Again, notice the tip of the dilator is what do you call it? Tapered, right? So with a tapered tip, I'm able to spread the fibers open. I need to do a disc of the anterior annulus. Shot? All right. So I just cleaned out any disc material that would be in the dilator tip. Shot. All right, once again, I'm going to do a discogram. Shot. And there it is again. You can actually see. Shot. Show the tear and show the dye in the epidural space. There's the tear right there in front of the dilator. Show the dye in the epidural. That's right. So you can see the liquid is tracking along the dura of the spinal cord. And actually it goes all the way up around to the back of your head, which causes headaches in these patients. They're called cervicogenic headaches. They're a common cause of treatable, the most treatable form of headache there is. And what I mean by, and I don't mean treatable, I mean curable. It's one of the only causes of headache that can be cured. Of course, you got occipital neuralgia, which can be cured as well. But this is the most common cause of curable headaches. It is a herniated disc or bulging disc causing headaches. Shot? All right, any questions from our audience? Shot?
Yes, we have a couple questions. This first one comes from John on YouTube. And he asks, if I have a protruding disc but have no pain or spinal cord compression symptoms, should I get ahead of potential future problems or should wait until I develop symptoms?
Wow, John, that is a brilliant question, John. Thank you. John, you know, you asked me that question 5 years ago, I would tell you no symptoms, no treatment, because that's the mantra or dogma that I was taught. But it's kind of like saying I found a brain tumor, it's small, not causing any symptoms, should I take it out or leave it alone? Well, of course you should take it out. So to answer your question, here's the reasoning, and I'm going to give you my answer. First of all, I don't have any proof scientifically yet that treating an asymptomatic herniation is the right thing to do for a patient. Okay? However, if you think through it, knowing what we do know now, which is that a herniation will eventually, it's causing inflammation, it's eventually going to cause a degenerated disc. That's the end result, degenerative disc disease, where you lose your disc and it collapses. You're going to lose the movement, you're going to lose everything. So could you justify doing this surgery to clean the tear, get rid of the inflammation that's going to happen or happening, and preserve your normal disc? I think it's a very reasonable idea. Now, let's imagine for a moment that this surgery did that and successfully. What you'd want to know is, what's the risk of the surgery, right? Because we know what the benefit could be, which is preservation of your normal disc and your normal movement and prevention of future problems like pain and radiculopathy, myelopathy. But the question is, what's your risk of doing the surgery? And if the risk is low, which it is low if it's done properly, which we've never had a complication with this surgery in 16 years. If the risk is low, then I think it's a very reasonable treatment option. I think you're right. It's a great question. So my answer is, if I did the surgery and you were a patient that, could do the surgery safely, you didn't have a lot of medical comorbidities, then I would say yes. It's a great idea. Do it. Preserve your disc. Save your disc. And it's funny because a long time ago when I started doing the Duke laser disc repair, we actually manufactured shirts for our employees, and they said, "Save the discs," taken from the Save the Whales mantra, and we had Save the Disc because all these surgeons are fusing your disc. They're ruining your disc, taking them out. Artificial disc, they're taking your disc out. ACDF, they're taking your disc out. So we were promoting save the discs and do the laser surgery. And I think it's a very accurate idea. Great question. Thank you for asking. Here's the tear. Here's all the herniation pieces. You can see them, the blue things popping out. There's another one. Okay. Oh, yeah. They're starting to block my view. This is so tight. So look at all the little herniations. You guys see them all? So this is another thing to talk about. Everyone thinks a herniated disc is just one big piece of herniation. It's not. Herniations occur over time, and they get worse over time. So you may have one herniation the first day that it ever happens, but then the second time you go lift a piece of furniture or play a basketball game or bend over and pick something up, then you herniate again and again. Every time you do that, every time you're active. So you're constantly herniating more pieces out throughout your lifetime. Eventually, due to the herniations and due to the inflammation precipitated by the herniations in the disc, then next thing you know, you got no more disc left. So, it just goes back to what we were talking about earlier. All right. So we're now at C5-6, and this disc, to me, is under less pressure from the inflammation, but it's also, I think, more damaged. It's more damaged than C6-7. You can see more pieces of herniation. You can see older, like that right there. That's definitely an older piece. Jeez. What do you think it is, Luis? I'm not really making contact. So what I'm doing, I've taken this out. I'm actually floating these herniation pieces out, because the alternative to floating is to try to grab them with the pituitary rongeur. But look how effective the laser is at debriding the annular tear. It's a debridement of the annular tear. That's what I'm doing. Okay? You can actually debride the annular tear, remove the herniation. Look at the blue stuff. That's degenerated nucleus. That's recent. That's all within the last 7 months. This goes along with the age of his injury. Look at the fibers of the PLL, posterior longitudinal ligament. Look at the scar tissue right here from the inflammation. That's scar tissue sitting on the ALL. Look below the scar tissue. See the white stuff is scar tissue with a little bit of calcification. We call it dystrophic calcification. And this is just damaged cartilage right here, which is attached to the bone. But you can see the fibers right here of the PLL, posterior ligament, posterior longitudinal ligament specifically. I have to be very careful here because the spinal cord is a millimeter away. I don't want to damage it. Look at this. This disc is pretty much almost done. More scar tissue right there. Now notice how the scar tissue is yellow. That's calcium. Well, when the laser energy interacts with the calcium within tissue that's damaged, it creates a golden, beautiful golden color. All right, I'm almost done. 5 minutes. I'm telling my anesthesiologist 5 minutes so that he can start preparing this patient to recover from the surgery, wake up. These surgeries are done under general endotracheal anesthesia. The cervicals are. The lumbar and thoracics are done under propofol sedation. And the reason I need this done under general is I'm operating on the spinal cord, not on the spinal cord, but next to it, and I can't have these patients moving. That's one of the things I did different than my colleagues over in South Korea, is they keep these patients awake. I think they keep them awake because they want to torture them, but you should see those surgeries. Now, they don't broadcast live surgery like we do at Duke Spine. We broadcast all of our surgeries live every week. From beginning to end, we have nothing to hide. We're very proud of what we are able to do for patients, and we want the world to see it. So we broadcast constantly. Every surgery, unless the patient tells us they don't want it broadcast. All right, I have to grab that out. Questions?
Yes, we have another question from Yvonne on YouTube. And they asked, Dr. Duke, what is your opinion on morphine pumps? I've had mine for 22 years. I want this thing out of me. I'm working on sending you my MRI results. I am a mess.
Well, first of all, I think morphine pumps are horrible, and I'm so sorry that you've suffered for so long. It's just a shame. There's nothing a morphine pump can fix there's nothing a morphine pump can fix at all. All it does, so for those of you who don't know what a morphine pump is, we used to put them in when I was a resident at UF in Gainesville in patients who had chronic pain. They were suffering terribly, and they were getting high doses of oral narcotics, opioids, which are obviously dangerous, to control their pain, and the doctors had no answer for them, no answer whatsoever. And so these poor patients would get these pumps put in, and it's basically a large reservoir of drugs, liquid drugs, morphine, basically. Nowadays, you can put other things like Dilaudid if patients are allergic to morphine or don't tolerate morphine. But basically, it's full of narcotic painkillers, and it's got a catheter or tube that releases the drug from the chamber into the spine, and specifically within the dura, or covering of the nerves. So it goes right to where, the nerves are, basically. The problem, early problems, that they would run out of drugs, patients would go through withdrawals, they could die, have seizures, etc., get very sick. I do not put morphine pumps in. I would never put a morphine pump in. Why? Because we can cure your pain with this surgery right here. 1 hour, give me 1 hour, your pain will be gone. Now, what's interesting to me is that if you had your pump put in 20 years ago, they didn't have MRI compatible pumps 20 years ago. And maybe they just started coming out with them. So you must have had a pump change along the way, and you probably got a newer pump if you got an MRI. So it just highlights the fact that these morphine pumps are not a one-time thing. It's not one and done. You actually have to keep dealing with it over the years. They stop working, they have to be replaced, their batteries die, whatever. They're just a pain. And the problem is they're being put in by pain management doctors because they pay so much money to get them put in. I mean, they're paid a lot of money, right? I mean, look at your insurance. What did they pay for that thing? They paid that doctor like probably close to $50,000. And a lot of that's profit. So these pain doctors are putting these pumps in left and right because they're making a killing profit-wise, and that's just unethical. They shouldn't be doing it. They're very dangerous. They don't work. I don't recommend them for anyone. Duke Spine, all we do is treat spine pain, you know, back, neck, arm, leg, and we don't put morphine pumps in. Dr. Patel is the head of our interventional pain management program. He will never put it in because he doesn't believe in the technology, and neither do I. So I'm sorry you have a pump, but we can definitely help you. I do need an MRI, and then we'll do a Zoom interview, and I can fix your problem. All right, looks like there's one more piece of herniation, pretty good size. I want to get that, and then we're going to wrap this up. We should be done in about a minute. And when you see me take the scope out and then put it back in, the reason is I'm floating out a herniation piece, and I don't want to have to grab it out. Grabbing it out is more time consuming and more risky for the patient. Any other questions? 1 minute. I think we're done.
No current questions, just a comment from Yvonne saying, it's my second one, Codeman pump.
Yeah, that's what I thought. Scope off. Well, I want to do a quick shout out for one person who I have a lot of respect for. And she may be watching today. Her name is Dr. German. She's the dean of the University of Central Florida Medical School. I've been a faculty there since the school opened, and I've dropped off for a few years because I've been so busy with our practice trying to help patients. And I met with her yesterday, and she and I had a great talk, and it sounds like the School of Medicine wants to bring Duke Spine Institute onto their campus. So we've started talking about that, and I'm going to start training residents and fellows potentially on their Lake Nona campus. That's what we're in discussions for. She's a brilliant woman, and she's been the leader of the medical school. She said she was the very first employee of the medical school, and now there's 600 people that work for the medical school. And she was obviously the visionary who made everything happen. I remember when I first visited the medical school, it was really the only building out in Lake Nona, and it was all surrounded by dirt. And we were the first, one of their first sponsors, Duke Spine Institute. So if you go there and you look at the bricks outside the medical school, there's a Duke Spine Institute brick that I donated. I can't remember how much money, but that was like one of the first bricks ever put in. All right. Anyway, she understands what's happening in spine. She shares my understanding, which is there's so many people getting unnecessary treatments. Epidurals, morphine pumps, spinal cord stimulators, interspinous devices, fusions, artificial discs, all of it totally unnecessary now with endoscopic technology. Look at this, folks. There's no metal, nothing. You guys see this? The whole surgery is done with a 4mm tube. You have a good picture here, Henry?
Yes, we do.
All right, so I'm going to put some pressure. I'm taking this contraption out. I'm going to apply a little bit of pressure in case there's any venous bleeding, which I've never had a problem. But sometimes you get a little vein under the skin. For those surgeons out there, the most common vein is going to be your external jugular running along the medial border of the sternocleidomastoid. I know that because I've seen hundreds and hundreds of them. I've done 1,000 ACDF surgeries myself in my career and artificial discs. I did a lot of vagus nerve stimulators when I was a resident at UF because I was studying epilepsy. I had an NIH grant. And I did a lot of vagus nerve stimulators. So I did that procedure every week for years and with Dr. Roper. And I learned the anatomy of the neck incredibly well. That's how I'm so comfortable doing what I do endoscopically. Okay, look, here's the incision. You guys see it?
We do.
And let's bring out the ruler. We'll get one more picture here, and then I'll come answer your questions. So, look at this, folks. Literally, I was a little generous today. It's 5mm instead of 4mm. So, thank you, everybody. Great job. Next surgery will be a Duke plasma rhizotomy for thoracic facet pain. Another procedure we developed here at Duke Spine Institute. All right, Henry, I'm going to come answer questions face to face. Folks, type your questions up. I'm happy to answer them. I'll do my best. Keep them on spine, and I'll be happy to answer them. Good morning, I'm Dr. Dumajian. It's December 9, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer, his procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now on my back, and Dr. Dukes is going to fix it next week, so I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed, but you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, doctor did. They did surgery on 3 different levels, and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
And there's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three level fusion, I don't know how long that would be, but it's
it's
terrible.
about that long
Yeah.
for a 3-level fusion. And then of course you'll have swallowing trouble for months,
Not
and
good.
then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Duke laser disc repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know, and my 10 younger brothers and sisters, if they're watching this, if you have back issues, you need to come see Dr. Duke, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his dukespine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these
Yeah.
surgeries,
Yeah.
and probably better than me.
Okay, thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yeah.
Good morning, I'm Dr. Ara Dumajian, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi,
Yes, sir. Oxford, Mississippi.
which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg, and went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Duke laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Duke laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone?
Gone, completely gone.
Cured?
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. I'm actually, it's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call, a spinal deformity doctor. And they possibly looked at like doing rods and pins and, and all that kind of good, the fusion and everything. So it just kind of...
Why didn't you want to do the fusion option?
Long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working at a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck, your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Duke Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday. And I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4 millimeter incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to Duke Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you so much. I appreciate it. Thank you so much. We will. Yeah. Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. And good morning. I'm Dr. Duke Majan, and literally I walked out of the operating room just a few minutes ago, and today we are treating a patient who has suffered with neck pain. His pain is kind of in the center of his neck, from the spine, radiating upwards to the back of his head. He has what are called cervicogenic. Anytime you hear the word in medicine genesis, it's referring to the beginning or origin. And what it really means is the origin of this thing, whatever you're talking about. So cervicogenic headaches means the headaches that are generated are coming from the neck or the cervical spine. So this patient had cervicogenic headaches, horrible after his accident, and pain radiating from the neck into the shoulders called cervicobrachial pain, and also numbness in his arms on both sides, and he was getting more pain on the left side. So we went in and found the source of the symptoms, which was a small tear in the annulus fibrosus along with herniated material. Now if you look at the MRI, 99.9% of doctors would say, I don't see anything wrong here. And that's the mistake. That's the mistake. Because what they're all looking for, unfortunately, what we've all been taught to look for, is a big herniation as the source of the pain. Big herniations don't cause pain. What they do is they pinch the nerves or the spinal cord, causing radiculopathy or myelopathy, which is nerve dysfunction down your arm, or spinal cord dysfunction in your neck, which causes balance problems, clumsiness of the hand, spasticity, bladder control issues. Those are the symptoms of a big herniation pressing on the spinal cord. Symptoms of a big herniation pinching a nerve is weakness in the arm, numbness in the arm, okay, and different dermatomes and myotomes. Long story short, pain in the neck, head, shoulders is always due to inflammation. It's never due to compression. And this is where Duke Spine Institute has departed from the standard belief, the dogma, the mantras of the last 100 years, which neurosurgeons are decompression surgeons. We decompress things. It's wrong. 95% of pain in the neck and back has nothing to do with pressure on nerves. It has to do with inflammation. It is inflammation. The inflammation is the cause of all the symptoms. And it's coming from a small tear in the back of the disc, as you saw at the beginning of this surgery. We ran a video explaining that. That's a video that I created at Duke Spine Institute years ago because we understood this concept years ago. And unfortunately, the rest of the world is not catching up. And people are suffering as a result of that. And people should not be suffering. They should not be suffering because their doctors are ignorant and don't learn the real truth about what's happening. And so we bring this knowledge to you directly to the patient. All right, I'll be happy to take questions. The surgery went very well. We fixed C5-C6, C6-C7, 2 discs, all right? And had this patient gone anywhere else and had surgery, they probably would have had a fusion. The surgeon I would have cleaned out those discs, put in spacers and a metal plate if I didn't know how to do endoscopic surgery. Endoscopic is far better. There's no metal, there's no fusion, there's no scar tissue, no bleeding, no hospital stay, no complications, no voice change, no swallowing difficulty where you can't swallow food or drink, no adjacent segment disease, no hardware failure, no infections. All that happens with open surgery. But with the Duke laser disc repair, 16 years, 0 surgery complications, 1,600 patients. All right. Any questions?
No current questions, so we do have 2 comments. One from Liz Lindsay on Facebook saying, "I'm super excited that I got to see new science made today regarding nerves." And then,
thank you.
And then for Sue Griffin, when we were talking about the training at UCF, she said that would be great for training.
Yeah.
Thumbs up.
So Miss Lindsay is a nurse I know very well. And a patient, and Sue Griffith is from England, and she's also a patient, and both of these women are extremely knowledgeable in spine, and I appreciate their comments. Yeah, Liz, wow, that was incredible, because, okay, look, see this model right here? The teaching in medicine has been always, and it continues to be, unfortunately, that when you have a herniated disc, say at C6-7, it's only going to affect the C7 nerve root, one nerve root, all right? And if you have a herniation on both sides, it can affect both C7 nerve roots, okay? But it cannot affect the C8 nerve roots or the C6 nerve roots, which are above. Well, today we did a discogram at C6-7, and we saw the C6 nerve root above and we saw the C7 nerve root below. Why? Because the dye left the back of the disc through the tear and migrated up and out on both sides. And what this shows you is that one disc can affect up to 4 nerves, even 6 nerves, if it affects the ones below as well. 6 nerves. So when patients come to the doctor and they're complaining about bicep and tricep problems, and the doctor says, well, it doesn't match your MRI, the doctors are being stupid and ignorant, and they are not using their brains to understand the patient's not lying, they're telling the truth. What the doctor has to recognize is that what we were taught was wrong, and that we need to relearn this stuff from our patients, the best teachers we can have. People don't always present with textbook findings, and when it comes to herniated discs, it's 95% of the time they're not going to have textbook findings. So if if you're a doctor and you're always looking for textbook findings to justify intervention or treatment or diagnostic testing, you're going to fail your patients. And it's got to stop. These doctors have to start thinking again and reasoning and understanding causation and change what they believe. I did that. I used to be a fusion surgeon, and now I'm an endoscopic surgeon. I still do fusions when needed, but I try not to at all costs for the patient. All right, any other questions? Hope you enjoyed our broadcast. We'll be back again in about 30 minutes with a thoracic multi-level Duke plasma rhizotomy. So at Duke Spine Institute, we've developed two major technologies for treating patients with back and neck pain. One of them is the Duke laser disc repair to fix disc problems. The other is the Duke plasma rhizotomy to fix facet joint problems. And just to give you an understanding of the difference, the disc is the most common cause of pain right here. The facet joint is the second most common cause of pain. And for every disc, there's a right and a left facet joint. So when we number the discs, we go C6, C7 disc. We say C6, C7 facet on the right, C6, C7 facet on the left. Today we're going to be doing, as a second case, a treatment of facet joint pain in a patient who injured their thoracic facets, multiple thoracic facets. I've never seen so many facets involved. And this is his fourth procedure. We did the upper left group of facets first in the thoracic, then we did the lower left, then we did the upper right, and now we're doing the lower right. So he injured the facet joints at work from, I think, T3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, I've never seen so many facets in my entire career injured, but the patient has been responding to the treatment amazing. All of his pain is gone in his thoracic area. He tried everything, epidurals, medial branch block, rhizotomy, and the only other option would be to fuse him with screws and rods from the thoracic spine all the way down to the lumbar spine. We weren't going to do that. Instead, we were doing the Duke plasma rhizotomy, a new type of rhizotomy done with, you're going to find out, a electrocautery unit. And you're going to see the technique if you come back in about 30 minutes. It's the second time we're showing it to the world. It's new technology. It's been, patent has been submitted for technology. And as a matter of fact, I'm supposed to meet my engineers here shortly who are going to be watching the surgery here at our center. So come back, enjoy, and we'll see